So someone comes to the ER and says, I swallowed something. That could actually mean nothing, or it could be a life-threatening emergency. Today, I'll walk you through how surgeons think about foreign body ingestions. What gets swallowed, where it gets stuck, when we scope, and when we operate. Foreign body ingestion looks very different depending on age and population. In children, the most common objects include coins, small toys, button batteries, and magnets. In adults, it's usually food boluses, especially meat, fish or chicken bones, dentures, pills still in packing. Certain populations are actually at higher risk, and those include elderly patients, patients with dentures, those who are intoxicated with alcohol, people with psychiatric illness, and prison population. The object matters, but where it gets stuck matters even more. So let's start at the esophagus, the tube that connects your mouth into your stomach. There are three classic anatomic constrictions in the esophagus where the foreign body may actually get lodged. The first one is the upper esophageal sphincter at the cricopharyngeus. The next one is where the esophagus crosses the aortic arch and the left main stem bronchus. Third is going to be at the lower esophageal sphincter.
Almost 98% of people watching this aren't subscribed. If you're a medical student or resident who wants to think more clearly, prepare more efficiently, and perform better under pressure, this channel is built for you. Click the like and subscribe button and let's keep on going.
Beyond the esophagus, the object can lodge at the pylorus, which is the distal end of your stomach, moving in towards your first part of your small bowel. The ileocecal valve, which is the transition from your small bowel into the right side of your colon. Other risk factors include people who have had prior surgery because of adhesions, risk of strictures, or presence of tumors. Sharp or large objects dramatically increase complication risks. So when is emergent endoscopy needed? Well, some swallowed objects can't wait. Emergent endoscopy within hours is required for the following: button batteries in the esophagus, sharp or pointed objects, complete esophageal obstruction, inability to handle secretions, and signs of perforation or airway compromise. Button batteries are especially dangerous because, like alkali burns, they cause tissue necrosis and perforation within hours. So not only in the esophagus, anywhere inside your gut, especially in the stomach, you have to retrieve it early because of that risk. Food bolus impaction? Yeah, a patient can swallow their saliva, so urgent endoscopy is again needed in this aspect. If they're stable and tolerating secretions, you may have time, but you still need to act. When is surgery indicated? So most foreign bodies are managed non-operatively, but surgery is required when endoscopic removal fails, there's perforation, there's ongoing bleeding, if there's abscess or mediastinitis, that's already a guaranteed perforation there, obstruction causing ischemia, and objects like multiple magnets causing pressure necrosis. Surgery may involve cervical exploration, a thoracotomy depending on where it is in the esophagus, laparoscopy or laparotomy. The decision is based on the location, symptoms, and complication, not just the object itself. Complications depend on time and object type, and they can be from esophageal perforation, as we mentioned, bleeding, infection and mediastinitis. Worse, you can actually end up with a fistula because of the perforation, like a TE fistula, strictures because of the inflammation that it caused, and bowel obstruction or perforation. Delayed presentation dramatically increased morbidity or mortality. What are the things I've taken out? Well, there's actually a lot for those foreign bodies that were swallowed. One of the things that was actually interesting is actually the pill cam, which gastroenterologists use for capsule endoscopy. Why did it get stuck? Well, when somebody has had multiple surgeries, sometimes there's going to be kinks in the bowel. The stool's able to manipulate that one, or the sulcus. However, this capsule actually got stuck and required us to remove it. Other things, there's a lot of people who swallow different things, especially those in prison or those with psychiatric illness. And these come from things which are metallic, in which you could use a C-arm to identify those objects, such as nails, springs. And for those that are non-metallic and don't show up with fluoroscopy, you have to palpate them and fully evaluate the whole abdomen. Other adjuncts that we use are CAT scans to look for sites which may actually show this, but it's very hard as well, even with these studies. Foreign body ingestion may sound simple, but it's actually a real problem that requires systematic thinking. Number one, ask what was swallowed. Where is it now? Can the patient protect their airway? And are there red flags that require any emergent intervention? That's how surgeons decide to observe, to scope, or to operate. If this helped your clinical thinking, please click the like and subscribe button and check out the rest of the channel for Surgery Explained Clearly. If you guys have any comments, please type it in the chat and check out our other videos and I'll see you guys next time.